Next speaker is Professor Vajira Dissanayake. Professor Dissanayake is the Senior Professor and Director, Human Genetic Unit, Faculty of Medicine, University of Colombo. And he is the Chairman of Commonwealth Center for Digital Health. I invite Professor Dissanayake to deliver his lecture.
Thank you very much for the invitation to talk. I would like to, first of all, begin by appreciating the work of Dr. Dolamulla. He's been, I got to know him when I was president of the Sri Lanka Medical Association. Suranga, you were Hambantota director, regional director Yes, at that time. And from that time onwards, he's been very energetic and doing new things. And I think as a postgraduate trainee in the UK for the past few years, he have been bringing so much to the country. And I think if all our postgraduate trainees go down the route that you have gone, Suranga, I think we'll be really doing wonderful things. So I must first of all congratulate you, and I hope you won't, get lost in UK and you will. Sanjoy, you can't give him a job. You have to let him come back and contribute to Sri Lanka. So it's indeed a pleasure to talk to you, and I was wondering what to say today. Coming from the background of digital health, when you talk of digital health, everybody focuses on IT and information technology. But when the word was originally coined in the book, which was titled Creative Disruption of Medicine by Eric Toffel, who is a cardiologist in the UK, the word digital health was meant to include meant to encompass how genomics and information and communication technologies would transform healthcare. So that was the broader definition. It included both genomics and ICT. So broadly speaking, the definition of digital health is how you apply advances in genomics as well as ICT to transform healthcare, to take it to the modern world as it were, because as you know, as we understand more and more of the genomics, we understand the basic functioning of the human being, the animals, the microbes, the plant world, and everything. So you really understand how what we are made of. I was listening to some talks recently, and basically we understand the software program that is running inside us. That's what we do. We never understood the software program that was running in us. We looked at the physical structure, but we now understand the software program. And we have only a partial understanding of it still, but as we go on, we will understand more. And when we understand that software program, we find that there's so much information, and that information has to be managed. And the only world in which we can manage that information is in the digital world. We need ICT tools. We cannot, that software program has 3 billion base pairs, so many ways of functioning, and the only way that we can really manage that is using ICT and information technology. So that is the the basis on which the word digital health was coined. But of course today we look at it, if you look at the WHO's definitions, they just focus on ICT, and they don't bring along the genetics of it. So let me then break this into my presentation into two areas. What can genomics do in terms of antimicrobial resistance? What can ICT do in terms of antimicrobial resistance, or tackling the problem of antimicrobial resistance? So if you look at genomics, today we are able to sequence any organism. So in our lab we can sequence any bacteria. So it can be done. And the high throughput platforms that are there enable you to sequence them at a very low cost. So today, like in my lab, we have a platform where we can sequence about 400 samples in one go, and the cost of sequencing will be $5, right? But we haven't really thought big. We haven't thought big. And therefore, nobody is using that platform to do this work. But if we look at in a broader scale of sequencing organisms, we can do it. And this is not rocket science anymore. Like I take undergraduate students who come to my lab for projects and train them, and they can run these without any difficulty. You don't need PhDs from some big research institute somewhere in the world to come. You can just train our undergraduates to do this kind of work. So when you seek, so what is the the expectation now when we do this kind of sequencing from a clinical scenario? You can get any blood sample, right, or any biological sample, extract DNA. So when you extract DNA, all DNA will come, human, any other pathogen, bacteria, anything else will come. And then if you are looking at the bacterium, you can just sequence. There are what we call universal primers. Using them, you can sequence all the bacteria in the sample. So when you do that, what we find in almost every sample that you come is that there is not just one microorganism, there will be a colony of microorganisms. So if we are to understand, so that takes us to the realm of what we call the microbiome. So in any pathological sample that you get, there may be a dominant organism, but there will always be that other organisms that come in. It's a microbiome which is present. So if you look at, if you Google the word microbiome, you would see that there are projects conducted in other countries. Look at the microbiome of different body sites. So there's the microbiome in the ear, microbiome in the nose, microbiome in the throat, microbiome in the gut, microbiome in the anything, even groin, everywhere. So understanding that is important. And if we are to tackle this problem in a global way, that it is important. So clinically, for example, you take let's say if you take a sample from pus sample from an ulcer, and you sequence all the bacteria which is there, you would find that there is a microbiome, maybe 5 or 10 organisms with one dominant organism. So the conventional culture techniques will help us pick up that dominant organism, but doesn't give you the bigger picture. So you keep on, you kill the dominant organism, the rest of the ulcers will continue, you try other antibiotics and so on, and this goes on and on and on, and you never, these kind of, but we don't really understand that bigger picture. You just kill the dominant organism and you go on, and then this kind of thing actually contributes to perpetuation of what we call this scourge of antimicrobial resistance. So we need to look at adopting these technologies. Unfortunately, Sri Lanka has lagged behind in adopting these technologies. If, for example, at MRI we have high throughput lab which only costs about 20 million to 30 million rupees to set up, and if the samples are coming in, you just set up the platform where you every pathological sample which comes, you completely do a microbiome, and when you do that, you can immediately do the bioinformatics analysis, which gives you the entire drug resistant pattern. So you you've got your set of organisms which are there based on the sequence. You predict it is resistant to this, 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 and then you can also predict which drug to give this patient. So you can completely customize a different way of treating this patient now. And there are projects like this happening, for example, in the UK. I know in the UK, the initial project which was happening was led by a Sri Lankan scientist there, Dilrini De Silva. So at Oxford, she ran that program, and they were setting up all these centers where you can get these samples from and coming. And so we need to move down that route where you use science to tackle this problem. Because as Dr. Benaragama said, we have failed in regulation, and the regulation is sentimental, and it depends on whether there is a strong person sitting in the regulators or not, and it's subject to other forces which are beyond us as mere mortals, or mere academics or administrators. There are bigger forces which are in operation, which we cannot tackle. And rather than that, we should be adopting science and using science to, tackle it in a different way. So that's my answers, my take on this. And, we'll be happy to work with the College of Microbiologists. In fact, I gave a talk to the College of Microbiologists in 2005, the year after I came back from UK, saying we should be doing this. For me, I can't do this alone. So if there is interest on the part of the College of Microbiologists, we can transfer the technology. I don't think currently as a human genetics unit we are interested in doing this kind of stuff. But we can guide you to do it and set up this kind of facility where the things can be done. And in today's context, what is 20 million, 30 million? Everybody now is buying a car which is more than that. So it is, peanuts to set up this kind of facilities. And so that way, we can tackle, using genomics, this problem of resistant to antibiotics. Okay? So that's the genomic story. And I'll be happy to have a conversation with anyone offline on this. The second story is the story of the digital world. How can you actually use digital technologies? Now, obviously, to analyze genomes, to analyze resistance patterns, and so on, you can use genomics. I'm not going to talk about that. But how can you use technology in our day-to-day practice? So one way to do that would be to use, get the guidelines that are out there to the desktop of the person or the hand of the person. And the way that we can do that now is through mobile devices, smartphones, apps, and so on. So the global level, there is currently now in our Commonwealth family, we have a Commonwealth Pharmacists Association, and they are working very closely with a group which is using this app, which is promoting this app called Microguide. So I was actually waiting there, listening to Dr. Benaragama's talk, and I just downloaded the Microguide app. It's called Microguide, and it gives, so in a standardized way, lots of organizations are putting their guidelines into this app. So Sri Lanka Ministry of Health, for example, can sign up with them. It's free. It's a European Union funded project. And the Sri Lankan guidelines can be loaded there. And Sri Lankan doctors can be told, okay, just sign up. So it's free, you can use. And so all the guidelines for use of guidelines in different settings. As you know, the guidelines vary, from pediatrics to adults to surgical to antenatal and all these kinds of stuff. So the guidelines could be put in a structured way and uploaded. That is something, Sir Dr. Benaragama, that we can even help you with, because using our biomedical informatics students who are in the Postgraduate Institute of Medicine program, we could get all these guidelines which are there and organize them in a structured way and work with this group and put all our guidelines and tell everybody, all the doctors, this is the guidelines are there, you all start using it. So that is one thing that we can kind of immediately do, and I'll be happy to get a student doing a project of that nature. Then the second thing is, of course, another thing that perpetuates all of these is fake medicines, right? Fake medicines and so on. So, so to overcome that, again, to verify the authenticity of medicines that are in the market. So the kind of tools which are used are like, for example, if all the authentic medicines that have come and they can be on a database with the NMRA or some organization, there should be the possibility of, let's say, when somebody has been given medical medicine pack, you take a picture and upload it into a. You take a picture of the the barcode in that pack. Then you upload it into a software, and it immediately gets verified. Now, this kind of solutions are there. Even in India, certain states, they are trying this out, I know. So, in Sri Lanka also, we can do that. So that, you just matter of introducing a barcode system to all the legitimate drugs which are coming into the market. So, and implementing this process. So, it can definitely be done, and that's also something that we can move towards. And the third thing in which digital technologies have been used is on supply chain management. Again, to make sure that the proper supply chain management has been done, and especially in countries in Africa, this has been done. So those are, I think, off the cuff 3 areas that I've seen technology being used, and we should adopt them. So we in summary, what I would like to say is that this is a problem that we should tackle using science and using technology, and we will be able to overcome all the other barriers that we have in enforcing regulation if we rely on science. And I think that is something that we should all, as coming from the medical field and the scientific field, be promoting. So thank you very much for inviting me to talk. I hope I have given a different perspective in terms of how we can approach this. Thank you.